Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we're learning about the Diabetes WA Telehealth Service, which uses video conferencing to provide education and support to people in regional Western Australia where local services are limited or do not exist. We'll be talking to Alison Ilijovski, Credentialed Diabetes Educator, who is often on the other side of the line, working in telehealth, as well as Gill Denny, Telehealth Manager, who is the Pilbara and Primary Care Coordinator at Diabetes WA. Approximately 1.7 million Australians are living with diabetes. Every day, 172 people are diagnosed with type 2 diabetes in Australia. And for every person who is diagnosed, it's estimated that there's one person who doesn't know they have it. According to the Australian Institute of Health and Welfare, there were more than 1 million diabetes-related hospitalisations in 2015-16, where diabetes was principal or additional diagnosis. In WA, diabetes-related complications are a leading cause of potentially preventable hospitalisations, with regional WA rates above the state rate. In parallel, regional capacity for diabetes education remains limited. The provision of comprehensive diabetes education, delivered by a credentialed diabetes educator, results in better health outcomes for people with diabetes, and the Diabetes WA Telehealth Service provides those consultations through regional and remote WA. So welcome Alison and Gill. Thanks for being with us today. First of all, what is the Diabetes Telehealth Service?
Thanks for having us today. The Diabetes Telehealth Service has been operating since March 2015. We're a service that's funded by the WA Country Health Service and WA Primary Health Alliance. So we've been running for 4 years. We service all 7 regions of Western Australia, and we're available to all regional consumers who are living with diabetes. We provide all our consults by video conference. We have credentialed diabetes educators who do those. And we're just aiming for equity and access for everybody who's living across regional WA. We have a diabetes education service. We also have a specialised gestational diabetes service. And we also have an endocrinology service, which I can talk about later. And we also provide health professional upskilling to regional health professionals, which is a fortnightly sessions, but again, I can talk about that later. We've had 1,500 referrals since we started, and that's equated to about 3,000 occasions of service. We've also, in our calculations, saved about 1 million kilometres in travel for patients when they don't have to try and travel a long way to access a local health provider. And importantly, we're a gap-filling service, so if a face-to-face service does exist in a regional centre, we'll definitely steer the person towards that face-to-face service. So we're really wanting to go where there is no local face-to-face service available.
So Alison, what patients can be referred to your service?
So our service is for anybody with diabetes. So we get referrals for type 1, referrals for type 2, gestational. We see anybody over the age of 17. Before that, it goes to PCH, and they have a telehealth service through there and it's anybody for rural WA. So not within the metro area, but anyone rural, and they're triaged into our service, and we see them according to need, referring triaged in, and the more urgent cases are seen as a priority, so our GDM we like to access and follow through quite quickly, whereas somebody who's newly diagnosed and quite well managed with diabetes at the moment, then we'll refer, that referral might take two or 3 weeks.
And Gill, will a patient have to pay anything?
No, there's no fee for the service. So as I said before, we're funded by WACS and WAFA. The way the funding is structured is to make sure that we have enough of a staff to see possibly 80 occasions of service a month, and there's no fee for the patients.
So Alison, who will the patients see?
So our telehealth service, we have a range of diabetes educators, our credentialed diabetes educators. We've got a team, we've got nurses, we've got dietitians, I'm a pharmacist. We also have an exercise physiologist. So the referral will come through. It will be triaged, like I said earlier, and then they will have access to one of our credentialed diabetes educators. We work together as a team. So if, for example, I have seen, as a pharmacist, I've seen a patient with multiple medications that requires a little bit of medication management as well as diabetes education, then I will refer and see the patient. If during the consult they then require a little bit more dietetic input, then I refer through to one of our dietitians and book in the next appointment with a dietitian, and then they'll be reviewed and come back to me. So we work together as a team, and it works quite well with the multidisciplinary aspect.
Gill, how do you refer into the service and how does the patient access the service?
The way we've got the referral set up, it's no wrong door. So anyone can refer a patient to the service, any health professional or the patient can self-refer. They just need to have the eligibility that they do have a diagnosis of diabetes. As Alison said, they need to be over 17 years of age and outside the care of PCH and be living in regional Western Australia. We've just got referral forms, but we also often help regional health services set up a referral pathway to us, because we know with regional health services and GP practices there's so much information and it's really difficult to remember who to refer to, so we try and support them with that. For a patient to access the service, it's via video conference, so they can just use their home computer as long as they've got an internet connection, or they can do it at a GP clinic, or they can also do it at a WACS facility or health service where they'll be supported by staff there. And we use various different platforms to make it as easy as possible. So really the only letdown is the internet connection where they live, which is obviously quite a common letdown, but we really try and make it as accessible as possible. We've even done FaceTime with some patients. Whatever works for them, we're happy to try.
Alison, what happens in an appointment?
So we like to make the appointment as much patient-centred as possible. So within the first few minutes, that's the first question I pose to the patient. What do they come for today? What do they want to get out of today? And then that, over the course of half an hour or 60 minutes, depending on whether they're an initial appointment or a follow-up, that guides how the conversation, how the review will go. So some people want to focus on nutrition. Some people want to have education about exercise and medications. Some want to know what is diabetes, how can I understand more if I don't understand what diabetes is? What do I use my blood glucose monitor for? When should I monitor? What do I look for? When should I go to my GP? So it really depends on the patient and that first question, what brought them here? What do they want to get out of today? From that, we can then set up some goals specific to what they want to learn and to follow up on, and then we follow them up depending on what their preferred choice is. So sometimes that can be weekly, sometimes that can be monthly, sometimes that can be 3 monthly.
How do you support the patient remotely and work with the local healthcare team?
We like to provide the service, and so yes, the patient is at the core of the review, but often the review is done within a GP practice. The GP can sit in, the nurse in charge or the nurse overseeing can also sit in, make it a three-way conversation, which I've found really helpful. Always like to refer back to local services where we can, so we are not there to take the place of anyone that's working in rural WA. We want to be there to support and to add on rather than take away. We ensure that the people that we know in the different regions, we can try and develop that team. At the moment we've got some good links with Karratha and the dietitians up there because their diabetes educator has recently left the area, so they've been referring into our service, and we're coordinating well with the dietitian in Karratha, which is working quite nicely. And then once they employ a new diabetes educator, then obviously our service, the local service, will take over and have that input. We also have a translator service, so if English is not their first language, we've had I've had a few appointments where interpreters been there, and that's really opened up the consult because the patient is there and they can understand, and it's been very valuable for the patient. We've had a few referrals for Aboriginal patients, especially they've been seen within the hospital prior to leaving. So, and in that case, I've sat in the doctor has sat in with the nursing team, and they've come up with a management plan prior to discharge, which has been quite helpful. And then following discharge, liaised with the Aboriginal health workers in their community so that transition is as smooth as possible where we can. We do encourage family to attend where possible, and if that's what's going to support the patient. Often, if it's a male, then we'll have a wife, and they're the driver of the appointment, and it's quite useful for them to take away different aspects of the review and get that whole what do they want out of the appointment again.
Kate, if I can just touch on something that Alison just said, which is a really good point to raise. So because we're a centralised service and we can cover all of Western Australia, we're often called upon to fill in if a local diabetes educator is on long extended leave for whatever reason, or they've got a diabetes educator has left and they're not able to fill that position, which happens quite a lot in regional WA. So we're able to come in and temporarily fill that place, and then, as Alison said, feed back to the new person who's in that position. And really we're the only service that can do that, and the reason we can do that is because we're centralised, we have all our governance and resource in one place, and we can filter and fill gaps wherever we need to.
Do you offer any specialised services for the patient?
Yeah, so at the beginning of this I touched on two of our specialist services, which is the Gestational Diabetes Service and the Endocrinology Clinic. So the Endocrinology Clinic runs one day a month on a Friday. We have Meg Hensey, who's the endocrinologist who runs that. It's all set up administratively by us, but she'll access MBS item numbers for her service, so it's bulk billed to the patient, so there's still no out-of-pocket expenses for the patient. She sits in our office, Meg sits in our office at Subiaco, and Alison actually sits in with every patient review, and we'll often have the patient at their regional site. We'll often be at a GP practice, and the GP also sits in, or for at least part of that consult. So probably a name for all of our services, but especially with the endocrinology clinic, is for upskilling local health professionals. So if they can be exposed to those consults and learn something on the way, that's great. It also lends to a really solid wraparound service. So we'll see that patient for a diabetes education appointment before the endocrinology appointment, because we just want to make that the most useful appointment it can possibly be. So we spend a lot of time making sure that patient is prepped and ready for their endo review. Then Alison will sit with the patient in endocrinology for that review, and then she will also see the patient after that review and do follow-up and feedback to the regional health services. Then the Gestational Diabetes or GDM service, we've got quite close links with King Edward Memorial Hospital, the tertiary hospital in Perth. They also have a telehealth service. They see more complex patients. So we'll see patients, we see them quite intensively, which is another benefit, I suppose, of the fact that we're a telehealth service. So we can see those women every week if needed. And then we can, if they escalate to needing insulin, we'll then refer them to the King Edward Memorial Service where they can get more intensive care. And we find the GDM works really well because we can be really timely. So if someone's referred and there's a local diabetes educator who may do outreach to their town and won't be there for another 3 months, that's too late for a GDM lady. They really need care straight away. And we've been able to link in with quite a few regional hospital protocols and pathways to get those referrals happening.
Gill, you mentioned that you offer training for regional health professionals and opportunities for upskilling. Please tell us some more.
So we have a formal health professional upskilling program. So we deliver a 30-minute to 1 hour upskilling session one day a fortnight on a Monday afternoon. that's offered by VC, and you can book through Eventbrite to access it, so it's very simple. And we send out a calendar a few months before, which is for 6 months, just to allow particularly nursing staff to organise their rosters so they can actually attend. We also record the sessions so people can watch them later. And they're on a variety of topics. We get internal speakers from Diabetes WA, our dietitians, diabetes educators. We also get external speakers, cardiologists and ophthalmologists and renal specialists. That's been running as well for 4 years, and we do a lot of evaluation of that and ask for feedback, and we base all our new sessions based on the feedback we get and what topics people want to learn about or want to talk about. So it's been really successful. And then, as I said before, a big part of the service is to support and upskill regional health professionals. So in addition to that, all them attending appointments, we can also provide support to clinical staff. So perhaps in a hospital, if they've got a patient that might be in for an acute reason or just starting insulin, possibly newly diagnosed, we can actually give them support around insulin administration with sort of how to use the pens and rotate sites and hypo management. We can't really sort of help in an emergency situation, but we can support staff to then educate the patients. We've also done things like continuous glucose monitors. We've supported regional staff in upskilling so they can actually then train a patient how to insert and use those. And then we also do quite a bit of, we try and encourage joint case conferencing, which is where we have the GP in with the patient so that we get that coordinated service.
Do you feel a video conference appointment is as effective as a face-to-face appointment?
It's actually a very effective way once people have got used to talking through a TV screen and relaxed a little bit. It's a little bit slower at times, and there can be challenges, so I can't show them a pen face to face, but I can show them as clear as I can, and they can have their own medications there. And we can. Recently, I've just had a patient who brought their blood glucose monitor in, but didn't know how to use it. So I had one my end, and they had one their end, and we talked them through how to use it and how to apply. So yes, it is as effective as a face to face, but yes, you do have to think outside the square a little bit, outside the box. We use sharing of screens, so I have 2 computer screens. One's with my camera and the other one is internet based, so I can share them videos, I can share resources that I'm going to email them or post out to them, and we can have the chat before. So a lot of picture based resources and things like that. Gill mentioned before CGM, that we've coordinated CGM. So we've recently done some Libre startups, so that's where they're using use of the flash glucose monitor for patients on insulin, or type 2 patients on insulin or type 1. They come in and we start them up, so the equipment is sent out to them, and then the use of the VC, we show the video and it's point by point. It teaches them how to apply the Libre and how they can use it, and then we follow them up. So use of VC and video technology and videos, it's been very useful to educate and guide. We use a variety of platforms like Gill mentioned. We've got Scopio, we've got Video Call, Skype. If all else fails, we will phone the patient up. The video call technology and all the platforms that we use have been easily accessed by ages. I've often had people say how easy it has been to access our service, and once they've started, especially recently with the video call, they've been very impressed that they can use their own computer. They can be sat at their desk, they can be sat on their couch. They're in their own environment and they don't have to travel. If I want them to go and see what medication they're on, they can stop the call and go and grab it from their kitchen or from their pantry. It's been a very useful and easy to access.
Alison, are there some instances where telehealth can be a better option for patients and their clinicians?
One of a good example to recall happened last year, middle of the year. There was a husband and wife travelling around Australia, so they were based in Brisbane and came across Australia, and when I saw them they were in Coral Bay. The referral came through newly diagnosed LADA, possible needs to start insulin. Can you see as soon as possible? So I saw this lady in her caravan in Coral Bay, and we talked through diagnosis and what had happened so far. The GP only visits Coral Bay every 2 weeks from Exmouth, so it was really hard to actually establish what was the diagnosis. Was it type 1, was it LADA, was it type 2? So there'd been a bit of a miscommunication between the time she'd left Brisbane and the time she'd arrived in Coral Bay. So it was trying to organise all that. So I linked in with their GP back in Brisbane, accessed the notes and had a chat with the GP there. Patient came and in Coral Bay, so spoke to the nurse and the nursing post in Coral Bay, linked then back to the GP that had seen her in Exmouth. All of that took time. It was actually a Friday afternoon, so it was trying to establish and make sure that if she was type 1 that she had been prescribed insulin and that there was something in place for over the weekend and that there was a safe protocol in place. Established all of that. It wasn't type 1, it was possible LADA. So it advised and counselled her about safe blood glucose monitoring, gave her target levels to look for, and reviewed her back on the Monday, and kept in regular contact with my lady. I can't remember her name, to be honest.
We probably don't need to say that.
No.
We just say we kept in regular contact.
You kept in regular contact. She was seen, like I said, only every 2 weeks by the GP. She was very scared. She had a bit of, didn't know whether it's type 1, type 2, didn't know who to believe. So there was a lot of trust issues with the medical system, and it was calming her down and allowing her the confidence to monitor, to eat carbohydrate foods regularly, to understand what a healthy balanced diet was, to add in exercise, all those kind of factors. We also organised for her to see our endocrinology telehealth service before she left, because she was still travelling around Australia, and she was actually coming back to Perth and then Perth to Bali. And before all of that happened, I linked her in with our endocrinologist so she could again feel safe. He prescribed a prescription for insulin for her to take just in case while she was away in Bali, and encouraged her to get the insulin just in case that, and then followed her back when she was back in Perth, back travelling up north. I think she got to far north, WA, and then handed her over back to her GP because she was travelling back and she was outside of WA. So it was really nice to see her progression from early diagnosis, take her through a little bit of a journey, give her some guidance, give her access to not just her GP but to an endocrinologist, which would not have happened in a timely as a timely manner if possibly she was metro based. So this all happened within a month. There's not many services out there that can access GP, access endocrinologist, and such follow-up as well in that month, initial month of diagnosis.
Gill, any other examples where telehealth can be a better option?
Yes, like I've mentioned before, particularly with GDM, because we can respond in such a timely manner. So one example is a young Aboriginal girl who was referred to us at 32 weeks gestation, which is very late but not uncommon because they often fall through the system and aren't seen by a healthcare professional until quite late in their pregnancy. Our first point of contact was with her GP. She lives in Newman. She saw the GP and then he referred her to the Port Hedland Diabetes Educator, which is over 400 kilometres away from Newman. Then she referred the patient to us, and then we contacted the GP to get her history. She was then encouraged to go to the visiting antenatal clinic that runs in Newman on a fortnightly basis. From there, we then organised for her to register with the National Diabetes Services scheme so she could access testing strips through the local pharmacy, and we also posted her up a blood glucose monitor because she didn't have access to one there. So it meant that she could start testing as soon as possible. We had really regular consults with her, so we're seeing her once a week via video conference, and that was at her home. We also linked in with the local pharmacy through the NDSS, and there was also a local dietitian, but she wasn't very confident in dealing with GDM, so we actually had our telehealth dietitian review the patient a couple of times as well. She was then, and all that time we were keeping the GP and the Port Hedland Diabetes Educator in the loop. The patient was then transferred to the Hedland Health Campus, again over 400 kilometres away, where we kept in touch with her and then handed over to the local DE and the midwives at Port Hedland. She delivered a healthy male baby, 3.4 kilos, and we also then did a 6-week post review, which is giving her information but also really encouraging her to go back to the GP to get screening because she's at higher risk of developing type 2 and also obviously GDM if she has another pregnancy. So it was just really good to be able to give that really comprehensive type service, particularly to young women who just don't have access to a local service.
Please tell us about some of your work in remote Aboriginal communities.
So again, telehealth is an effective tool to use for remote Aboriginal communities, or I guess remote any communities. We've had limited success, to tell you the truth, and we think that's probably mainly based on capacity and resource within the Aboriginal medical services in those communities. So we do run a couple of clinics. We run 2 Noongar Budja clinics, so we video conference into Mora and Merredin. The clinics are running, and then the health staff or the Aboriginal health workers will bring the patients in to see us via VC. So when the clinic's really supported, it works really well. To try and do individual appointments with Aboriginal people has been a little bit more difficult for us. We also do video conference into several AMSs, and we've also supported staff in AMSs. So, for instance, the chronic disease nurse in the Broome Regional Aboriginal Medical Service needed support with a patient that was commencing on insulin. She'd never done that before, so we actually did a video conference with her. We sent her up some practice pens, then we did a practice with her via video conference and talked about hypo management and rotating site and how to use the pens, and then the next week she brought the patient in and she sat with the patient, and then we did support and education for the patient around the commencement of his insulin, which was fantastic. So that worked really well. But to try and address the limits that we've got with remote Aboriginal communities, we put in an application to the Google Impact Challenge, which is run every couple of years by Google. It's a national event, and surprisingly we actually were one of the 10 finalists, so we were able to win a significant amount of money in a grant, and the basis of that is to spend time engaging with 3 selected Aboriginal communities to find out what barriers they might have to using telehealth and what we might be able to do to help them co-design a service that will work for them. A lot of that might be initially visiting and developing trust and then delivering the service. It's just that we're a little bit short on resource, so we can't do that visit normally. So we've only just started with the Google Impact Challenge, and that's going to run for 2 years, but hopefully over that we can co-design a service and a platform that works, and that can also be replicated with other chronic disease support. So it's a space we're really keen to work on. We spend a lot of time trying to make it work, and we have had success in some communities.
Can I just add,
Yes.
to go back to what Gill mentioned about the starting of the insulin, I was the educator involved with the nurse and with the patient, and it really does show, it was really rewarding as a practitioner when the patient engages. So Aboriginal patient sat there with the nurse. It took, I think, 3 visits for him to actually look at me through the computer, but that support that he had with the nurse at the end within the medical centre. And towards the end, I think we had about 5 or 6 visits in the end, something like that. But towards the end, he was telling me about his grandchildren and telling me about sports and how he'd engaged in that. So, yes, there was apprehension to start off with, but we overcome that, and it was a very rewarding case.
So Gill, if people would like more information, where's the best place to visit?
So the best site would be our website, which is diabeteswa.com.au. We've got most of our information there and it's fairly easy to navigate. If someone did want to contact me directly, I'm more than happy with that. And my email is gill, gill.denny, denny, at diabeteswa.com.au. We also have a helpline that runs Monday to Friday from 8:30 till 4:30, and it's there for consumers and health professionals. It's managed by Credentialed Diabetes Educators. And if you'd like to call that, the number is 1300 001 880.
Gill and Alison, thank you so much. It's been a pleasure chatting with you.
Thank you for giving us the opportunity. We hope that our listeners will be able to fully understand the Diabetes Telehealth Service and refer in. We look forward to having new patients.